How are we doing? Very good. Actually, I just want to have a little personal talk with Richard Late. Richard, they've stitched us up here. What happens is the minister comes in, does their talk, then leaves, and we have to get all the sticky questions. So anyway, but fortunately I know that we're being videoed, so hopefully this is going to be relayed to the minister later, so they can pick up. So any questions I can't answer, we'll just capture on film. Very good. Okay, what I'm going to do now is I've been given the unenviable task of giving a bit of a report card on where we are and what progress we've made in the first year. I'm going to restrict very much my focus to the UHI and the hospital system, if you like, and I realise that's only part of the whole story, but the minister was looking at some of the primary care stuff before that. I just want to acknowledge some of the stuff that I'll be drawing on is work with colleagues from ESRI, particularly Conor Keegan, who's been helping me look at the resilience of the Irish health system, Sarah Barry from Trinity, who's been doing some good stakeholder interviews for me, and also Mary O'Riordan from NUIG, who's also been very useful. And some of her ideas I'm nicking here, so it's flagrant and terrible, but she gets all the glory. Okay, going up the down escalator. I thought this was a good paradigm to use, really, because I imagine, I've never sat in the seat, but being a health minister means you have to do a lot of fighting of fires. Being a health minister in a recession, it's probably even more tricky, where you're even just fighting to stay where you are. And then being a health minister and in a recession and trying to bring a vision to implementation is probably quite a tough call. So we can certainly see we've got a down escalator at the moment, and I want to think about three different things that are causing some downward momentum that in essence is actually shaping the design of policy and shaping the implementation of policy, and we need to think about it because we need to be aware of what the constraints are for what's going on at the moment. And the three things really are, first of all, the recession, the depth of the economic squeeze and the potential loss of sovereignty now, as the Troika run most of our macroeconomic affairs, and as the German Parliament decides what we're spending before we do. Then the second issue is the weight of history. This is universalisation for the first time, and I think that's quite interesting to reflect on within the Irish state. And then thirdly, the choice of design, because I actually think that the specific choice of UHI that's been chosen or developed or is under development actually may cause us more problems. There may be a sting in the tail later on. We might not see it at the moment because of the recession, but I think there may be problems with the actual choice of design that we've gone for. So I'm going to start off with that before I then actually get on to the actual, well, what has the progress been? So first of all, the recession, well, how bad has it been? We decided that we would actually do a bit of research on this. We did some comparative analysis of, well, who's had the worst recession? You know, is mine bigger than yours and all that kind of thing. And we looked at unemployment, we looked at debt to GDP ratio, we looked at contraction in the economy, and we found that actually Latvia is #1 place to not be right now. Okay, I don't know if there's anyone here from Latvia. Sorry, you picked us to the post. So Ireland only has the second worst recession in Europe. So, but we're doing quite well. I mean, I know Greece is probably catching up rapidly, but we have had an incredibly bad recession. It's still going on, and the ramifications of it in terms of the debt crisis and the banking crisis. Even if the economy returns to growth, we still have a huge gap in terms of our government deficit. So we've seen £2.5 billion taken out, or being taken out of the health budget. We've seen a cutting of staff. We've seen cutting of patient entitlements. Our over 70s don't have free medical cards anymore, not on a universal basis. We see our medical card patients, getting less and less dentistry. We've seen an increase of co-payments in terms of what I pay before I get reimbursed for my drugs every month. So we've seen lots of cuts. But at the same time, interestingly enough, we've actually also seen quite a significant lowering of costs and actually doing more with less. Our hospitals are now actually doing more with less. It's true. The number of day patients is up, the throughput is up, average length of stay is down. So it's interesting, at the same time we've had these horrendous cuts, we have been forced to make efficiencies. And we keep hearing about this kind of recession dividend. And I think to a certain extent there's some truth in that. So it may not be all one-way traffic. And these are some insights that we had from interviewing policymakers recently on the effect of the recession. And they say, well, the system is more resilient than it appears. It could also be the case that there was a lot of flab. And interestingly, if you look at Latin America in the 1980s, the health systems that survived there were those that were quite flabby. Okay, so that's quite an interesting thought. So maybe we've kind of had to trim down a bit here. Another quote said, when we start to spend on services again, it'll be in a better way, a more structured, efficient way. So maybe the way we were allocating resources before wasn't so clever, and now we're having to think about it a bit more carefully. But at the same time, there is a sense in the system that the low-hanging fruit have already now been picked. Okay, we've made the easy efficiencies, now where do we go from here? And there's a concern that we are no longer masters of our own destiny. So that's certainly a very key contextual factor that we need to take into account when we're thinking about what progress we're actually making. The second is the weight of history. And the idea of path dependency is that your current options are moulded by your past choices. So in other words, if you look really at the history of the Irish state, at key points, we've chosen not to go for universalisation. Maybe back 100 years ago, 1911, there were opportunities there to have more universal service. 1940s, 1950s, and throughout the history, there have been key points where we said, no, I don't want to go for universalisation. Actually, and the idea is sort of that, if you like, have prevailed at that time, have been more around having a perhaps more individualistic ideology, perhaps listening to vested interests more, not thinking about the society as a whole, perhaps even a preference for profits, efficiency and the market. And the idea of social solidarity, that's perhaps been something that's been missing, although it's interesting to see whether that's changing at all. I know that's something that TASC has been looking at. But at key points in the past, we've chosen to back away from universalisation. So it's interesting now that we have chosen to adopt it as a society. And why is that? Why is that? Have we just changed? I would say no. I would say we haven't changed. I would say actually what we have in the form of universalisation that we're choosing is actually something that accords to those past values. We've come up with a UHI system which is sort of private for profit, individualistic, choice-based, and maybe placed in some of our vested interests. And sort of a neo-Dutch model, shall we say. I know we can't say it's a Dutch model anymore, but it's kind of influenced from there. So rather than escaping our history, I actually think we've gone along with our history, and we've chosen a universalisation option that fits with our past choices. Anyway, so, which brings me on to my third downward momentum force, compulsory private insurance. I'm going to call it that because that's what it is. It's compulsory private insurance, really. That I'm concerned about. If that's our end goal, I'm a bit concerned about that. If you look at other systems which rely on private insurance, like the US or the Netherlands or perhaps Switzerland, they have two key features. They are complicated and they are costly. Cost escalation is a key factor. Multiple competitive health insurance models do not lower system costs. We cannot expect them to. That is a fact. If we expect that to lower our system costs, it's not going to do it. why not? Surely competitive forces, driving the, responding to people, driving down prices. Well, I think there are quite clear reasons why not. A, they need to make money, because that's what private companies do. They duplicate administration and purchasing. You could have consolidated that. The administration costs are high. They're difficult to ration because there's really no incentive to control costs, because other people are paying. And also, a key concern is that where they can, private health insurers will get profit first. They're not bothered about cost reduction, and if they can choose the young and the healthy to insure, then they're going to get nice fat profits in a community-rated scheme. Then the key focus isn't cost reduction in that system; it's cream skimming. Okay, so all those reasons that I think contribute to the issue of cost escalation in these other systems. And we look at Ireland. We've heard this before. Let's say it again. Ireland is too small a market. We only have 4 million people. There are about, I don't know, whatever it is, 16 million people in the Netherlands, with basically 4 main groups. 16 divided by 4 is 4 million people. Okay, 4 million people per group. Okay, that's one group for Ireland. Yes. Okay, even my simple maths gets that. So, and we know big funds can work quite well in terms of purchasing. They can do quite well in terms of economies of scale. So it's not necessarily efficient to have lots of little funds working and competing. And also, what have we actually got in Ireland? We've got a few. We've got 3, basically 3 funds. 3 funds is what in economics you call an oligopoly. Oligopolies are famous for not lowering their prices. That's the key feature. They don't lower their prices. They have a nice, cosy little number going on. We all charge about the same. And if things may go up, but they never go down, and we compete on non-price issues. That's how oligopolies work. So, for all those reasons, I would say that if you're looking for cost control, this is not your option. And yet we're in the middle of a recession. Okay, so we have a worry, a fear. In the Netherlands, the basic package is shrinking, cost of add-ons are spiralling, cost escalation. Universalisation will not be affordable in the long term with this model. That's my worry. My worry is even if we manage to get it in now and the recession drives down our costs sufficiently, once the recession is over, cost escalation. And then we can't afford it, and then the package shrinks, and then we get universalisation of less and less, and we get people buying the basic care in a supplementary manner, and the whole thing unravels. That's the fear. So those are our 3 downward momentum forces, if you like. Okay, now I've done some in-depth research into how to climb up down escalators. Okay, I've watched my children as we go to the airport, and I've done some case studies on them. And they like to do 2 things. They like to go up the down escalators, and they like to go down the up escalators. I think probably going down the up escalators is probably like what Andrew, whatever his name is, Langsley, is trying to do in the NHS. But that's a different technique. But when you go up the down escalator, you've got to be clear about what's the steps in front of you. You've got to be very focused on the steps. You have to move quickly, otherwise you don't get anywhere. There will be some tripping up. You will get bruises. There's so many things to do. You're going to fall over, but the essence is to keep going. Okay, so let's see. So what are the steps to take? What steps do we need to take? This is assuming that we're all agreed that where we want to go. And basically what I've done is drawn together some points here from some of the Adelaide reports and from some of the work by Charles Normand on social health insurance. And basically I think there are 4 basic things, 4 basic areas that need to be looked at. And we can measure progress against this. We need to expand capacity. Number 1 issue. We need to do more. Social health insurance, universal health insurance systems do more because they universalise. Therefore, unless you're going to have enormous great waiting lists and everyone getting annoyed, then you've got to do more. Okay? Secondly, there needs to be organisational change. You've got to move towards a contracting model, different from what we've got at the moment. And in all likelihood, if you've got these private companies competing, you need a strong regulatory capacity to do that. And they've certainly needed lots and lots of people like that in the Netherlands to manage their system. You need a new financing model, looking at funding flows, looking at risk equalisation, which as Vin van der Ven says of the Dutch model, that it is the risk equalisation is the heart. It's the heart of the private insurance model. So if you've got to get that right. And then you also need stakeholder management. Are you taking the people with you? Okay, so let's look at those 4 different elements. Building capacity. UHI systems, they will do more. They universalise care. They free up. They remove the price barriers. But we can't afford to, build more hospitals, train more people, or whatever else. We've got very limited. So we have to focus on efficiency. Okay, that's the only way we're going to do it. Efficiency, productivity. If we haven't got any more resources, if our resources are coming down, unless we somehow protect some and put some extra money in, which there may be a bit of wiggle room, but basically we're going to have to look at efficiency. So, what have we seen in the first year towards that? Well, we've brought the SDU has been brought in, and that's focusing on reducing waiting lists and dealing with some of the emergency departments. We seem to be doing quite well in the hospitals in terms of more day cases and average length of stay coming down. I mean, I know Richard has noted the vast potential for shifting some of those things, and that might be right, but we have seen progress. In terms of some of the hospital networks and how that's beginning to work, transferring some of the patients to the hospitals which are less utilised to try and manage the patient load, that's starting to happen a little bit, and the clinical programmes and the models of care are being developed and being slowly brought in. So we're seeing an understanding that the capacity needs to shift, an understanding that there needs to be more efficiency in the system, and the beginning of steps taken towards that. So, not bad. Building capacity, yeah, not bad. It is year 1. Secondly, contracting model. Some progress here. Earmarking, ring fencing of funds in the last budget, and we're talking about earmarking some of the primary care funds, and that's coming into play. So that's quite good. There's the idea of having the 7 new directorates within the HSE, which I presume is going to be a kind of a stepping stone towards commissioning. I assume that each of these directorates will be looking at commissioning of services, or there'll be some commissioning involved with that. My concern there is that there might be fragmentation in the commissioning and how you manage the overlaps and make sure there isn't sort of perverse incentives for the primary care people to dump people on the hospitals and the hospital people to dump people on the primary care system and all that kind of thing. So how that works, I'm not sure, but there's starting of that. There's the idea, the kind of development of the hospital trust idea, the beginnings of autonomy, which you need in a contracting model. There's also the money follows the patient experiment that's being trumpeted very loudly. We've had these incentives for whatever is same-day orthopaedic procedures, and believe it or not, wow, incentives work. My goodness. And it's like a big surprise. The minister comes in and said, "Hey, it works, it works." Well, yes, it does, yes. If you give people cake, they'll eat it. It's not a surprise, but incentives work. So, but a money follows the patient idea for one set of procedures in one particular area is very good and well done, it works, but there's so much more to be done. So a huge, great diversity and complexity of different incentives that you need to be looking at here, not just one thing. So the question about it, I would say there's a start, but there's so much more to come. So, contracting model, the beginnings. Fine, good. Not a lot happening on financing, really, I have to say. There's been no white paper. We've been promised that. It doesn't seem to be there. There was a lot of talk in the air, shall we carve up VHI? Shall we carve it up?
Scrap it.
Sorry?
Scrap it.
Scrap it.
From the first day and then still around our neck from day 1.
We'll come back to that. Should we carve up the VHI, split it up, increase competition? Should we? Let's buy up a Quinn. Let's buy up a Quinn, merge it with VHI, slice and dice everyone, so we get the risk. So there's sort of a more even risk, if you like, distribution across the insurers. Hasn't happened. Okay, so there was a lot of smoke and mirrors there, so none of that really went ahead. I'm not really sure where we're going with that. Not very clear. We hear there's a risk equalisation mechanism coming. We haven't seen it. The insurers have seen it. That's very nice of them to give them a nice bit of forewarning there. We know it's not as sophisticated as the Netherlands. That's good and that's bad. I think the Netherlands one, I mean, they've really worked very hard to try and make sure that you can't cream skim. And I applaud that. I mean, you can never get all the way there, though, because risk equalisation, you can never compensate fully. So that's slightly doomed to failure. But without knowing what's in there, my worry is they won't be able to get rid of that incentive for the insurers to actually cherry pick stuff. And then we've got the setting up of the Health Insurance Consultative Forum. Very good. We don't know what's going on there, but it's been set up. Well, that's what you've got to start with, I guess, getting to know you. Lastly, bringing people along. How do we, take everyone with us and everyone be happy about what's going on? Breaking up the HSC, I mean, that certainly played to the galleries. A lovely piece of theatre with the minister going, down there on the 6 o'clock news and knocking on the door and, telling them to get packed up and all the rest of it. So that was a good piece of theatre. People like that. I think for me the lowest point, though, was the threatening to charge the medical card patients €50 before the last budget. That was a stinker. That was a real trust breaker. Now, it could have been, in political terms, it could have been taking out the garbage, which is basically you make a big fuss over here. It's a bit like a bad magician. You make a big fuss over here so that you can release some bad news over here. Nobody spots it. It could have been something like that. It could have been a deliberate distraction technique. But it looked like the government wasn't serious about universalisation. It looked that the government was falling over at the first hurdle in terms of their policy commitment. So that wasn't so great. I don't think that was managed very well at all. And in a situation where you need to take people with you and you need to build trust, I don't think it did that at all. And particularly coming over a few months where there hadn't been much communication, I don't think that was that good. Having said that, I think probably from about the beginning of February, there's been much more of a push towards communication and vision and architecture setting out. And certainly starting with the Minister's plans at the SDU meeting in February, which we saw some of today, there's much more of an idea of how this sort of system architecture is starting to sort of be put together, and some of the timing. Lots of details missing. They're clearly building the ship as they're sailing it, but at least there's much more of an engagement now with the media. And we've also got the setup of the implementation group, and we've got our beloved experts and champions on that, so hopefully we can see some things there too. So, progress to date. Look, it's been the first year. There's been a certain amount of discovering the levers of power. I think Henry Kissinger said it took him about 3 or 4 years to discover the levers of power, and when he got hold of them, he found they weren't connected to anything at all. Now, I don't know what the experience of the ministers is behind closed doors, but you never know. I would say, actually, that the progress is more than is first apparent, actually. And, given some of these downward forces, that's no small achievement. There's been a focus on capacity, trying to sort some of the issues out there, which are long-standing. There's been a bit of an outlining of system architecture, and there's been some establishment and setting up of SDU, Insurance Forum, Implementation Group, etc., etc. I think on financing and communication of vision, we're only just getting started. And I think the report card is probably not as great on those two. So, basically, in conclusion, I think there are some very strong forces impeding progress. I know there is a recession dividend, but the problem is where if things get extreme, where finance tries to claw back some of these efficiencies. At the moment, there is the hope that the efficiencies that are made will actually be allowed to be ploughed back into the health system. But if finance takes those out, because it needs to meet all its conditions from the Troika, then those efficiencies won't give any dividend to the health system. And we clearly have a long way to go. And I would actually argue that the model we've chosen is complex, and that complexity means we've got further to go than we would have otherwise. I think particularly this multiple private insurance system is more complicated, it will take more setting up, and it therefore adds extra steps to the escalator, if you like. There has been definite progress in year one. Things are happening, and generally in the right direction. I think there are still some critical design issues. There's still quite a few gaps. We really don't know, what some of the answers are. And my final concern is, even if we get there, even if we have the UHI system in place, will we be able to afford it in the long run, or will the system start to be characterised by cost escalation so that we get to a situation where ultimately we can't afford it anymore? Okay, stop there. Thank you.
Pick them up. One is, on your next date, go neo-Dutch. And very good news for the likes of me, which is don't lose too much weight, because those with a slightly increased BMI seem to survive longer, so that's reassuring as well. But to be serious, we have some time for questions, so Austin.
Sorry, my question is probably more for our absent minister, so I hope, in case this gets to the video, I suppose the issue was that if they're talking about opening up primary care access to everybody, how are they going to take into account that if they're giving same payments to all GPs for each patient, the fact that in areas of deprivation there's a higher need, higher morbidity and higher mortality statistics? So does anyone know, is there any plan to ensure that there isn't a disincentive still for GPs to get paid the same amount in a far busier area, and also about the distribution of nurses and physios, etc.? Are they being addressed to reflect that increased need in areas of deprivation?
I would imagine that there would have to be some kind of targeted incentive for areas which are more deprived. So I think that the basic capitation payment is probably the basic principle. But I would say that there would be a few bells and whistles on top of that. Now, that's conjecture, but I would imagine that there will probably be targeted incentives for geographic location, but also maybe even for chronic disease management as well. So that would be my guess. But I think probably what they're trying not to communicate is a sort of mass movement away from the current system, so that people aren't concerned. Because I know one of the concerns I think previously has been that if one moves to a Dutch system where it's much more fee-for-service, the incentive picture changes radically. I don't think it will change that radically, but I think it will change slightly, and one of those things will be towards redistribution, a little, towards some of those deprived areas.
Alice Lee from Trust. To follow on from Austin there, when we're talking about commissioning of services, is there not a danger that the emphasis will be put on those who are likely to be successful? Because the experience is working in the area of poverty, that grant aid is dependent on outcomes, and the ones who are likely to be successful and achieving great success, even though it isn't success, get the money. But when we're talking, the emphasis is very narrow on health care. And I would wonder, are the ministers here today, there's no reference to carers, to home helps, to rural transport. All of this costs money, and yet while they're talking about rolling out services, they're cutting back on those services in the most isolated areas in rural Ireland and in urban areas. And I would also ask if anyone representing those groups are involved in the discussions round the table far from here.
Alice, I think that's an observation, perhaps rather than a question for Steve, but thank you for that. The chap.
We are now experiencing a doom and gloom, not just a swamp. I was coming here this morning, and one person I could think of was Bridget Colgan from Donegal and Susan Long, the families of Susan Long. Do we have an inspiration or a vision rather than a private care system? Because seemingly it has failed and has nothing to offer. Are we looking at models of, instead of Thatcherite models, why aren't we looking at models that put people first, such as the Cuban healthcare system? Why aren't we working on those models instead of models that have failed? When you look at the HSE under Miss Neve Brennan, the ex-Minister for Justice wife, and these people, and Mr. Mannis of the horse, involved in the horse racing sport, we should be putting in socialist model healthcare, and to hell with the Thatcherite Harney agenda and O'Reilly agenda.
Thank you.
I actually will respond to that because I think it's quite an interesting thought. If you look at the programme for government, we really don't get to UHI until 2016, and really, realistically, it's probably going to take a bit longer. And the primary care universalisation is actually going to happen within the public sector. So there's nothing, you know, I mean, you are contracting care to GPs who are private, but in essence, it will be an entirely state-funded system. So that's not a million miles away from that, and there's no reason for you to have an insurance mechanism in that. You might call it a primary care fund and a primary care insurance fund, but there's nothing particular about that in a sort of competing model or anything like that. So that part isn't, I would say, any sort of relic of Thatcher or Reagan. I would also see that, you know, you could probably shorten the escalator if you actually moved for a single fund system. You'd make it less complex, easier to do. You would avoid some of the problems. You'd still have issues about incentives and how you can drive down costs, but at least you wouldn't have any problems around cream skimming.
Okay, this gentleman here on the right. Thank you.
Shane Hogan from the National Disability Authority, and thanks for a very practical and easy to follow presentation. Just wondering if you've seen anything about particular impacts of universal health insurance on people with disabilities. We did commission some research which we'll be publishing in the next couple of weeks, but it was very difficult to find concrete stuff from around Europe on those particular issues. So if you do have any insights to share, it'd be great to hear them.
That's it. I have no idea. I mean, I have not seen anything on that. I mean, I think it's certainly an area that really does need a lot of focus and hasn't had it. I think the working out of the issues of access and eligibility and even packages of care needs to have a much more. I mean, there's such a lack of research in many of these areas that a lot of what we're talking about here is quite broad brushstroke and needs to be populated with much more of an evidence base. But I think now is the time to do that.
It's just a follow-on from what someone else said. You can't have primary care just set up as GP practices. Primary care involves physios, OTs, public health nurses, community RGNs, and that is spoken of absolutely nowhere in the Minister's idea of primary health care. It isn't primary health care, it's just setting up GP practices, and that's all.
Hello. I just wanted to say, how can we move to a single insurance provider? It's obvious the disadvantages of multiple providers. It's a stop towards this idea of competition. And as you explained, it's obvious it doesn't reduce costs. What can the public do to change the government's mind? And you mentioned other opportunities we had to go for a universal system. You mentioned 1911, you mentioned post-war. The big opportunity lost was in 1995 when the VHI Amendment Act was brought in. As somebody who campaigned against that, no representative group were campaigning against it. And that was an opportunity to bring in a single provider universal system. But that opportunity was lost. And it was the Rainbow government who threw away that opportunity.
Yeah, I don't think it's set in stone yet, even though Minister Riley does clearly. We have an election coming, what, in 2015 will it be? There'll be opportunities to change things there. I would see that the current recession, I actually think we may be getting to a tipping point with private insurance. People held on to it for a very long time, given the depth of the recession, people were still hanging on to it. But I think things have got so bad now that people are starting to let go of it. And the more people let go of it, and we're seeing 60,000 last year, and with a couple more years of austerity, that will snowball further. Then the rationale for moving to a multiple insurance system, decreases really. So that if private insurers say, well, actually, I don't want to work in this market anymore, then you are de facto left with a single insurer, which will be your VHI morphed into something else probably. But because it just becomes a less attractive place to do business. So I wouldn't say it's lost. Keep pressing.
Okay,
Steve, thank you very much for that clear expose. But I want to take up one little point at the very beginning. You were quoting the Netherlands and the United States as private markets. Now, I'll be talking about Holland later, but I think as to the United States, it's a grave error to try and depict the US as a private health insurance market or a private system. That simply isn't true. The US actually consists of 5 major subsystems, and that's important because you'd miss the opportunity to learn from it if you just say it's a private market. It has Medicare, that's social insurance for the elderly. It has Medicaid, a state-subsidized system for the poor. It has the Veterans Administration, one of the best working health systems in the world, extraordinarily efficient, very interesting. It's basically America's socialized medicine. It has employment-based insurance. It's a bit complicated, but it has enormous amounts of insurance that cover 85% of the population. And there's, of course, the drama of the 15% of the population who do not have insurance. But calling that a private market would be really missing how the US system consists of a mix of all those different elements with predominantly public funding.
Kika, I can always rely on you to ask me difficult questions. I would say that the government isn't the majority funder in the US. I agree there are different sections of and different systems within it, but the private insurance is certainly a very key factor in it, and probably explains why cost escalation is rampant and they spend so much on the health system anyway. So I think maybe I was being simplistic, but then I think probably single labels for any health system are quite simplistic, and one needs to look at the underneath of it. My mere point was to make out the point that actually cost escalation is rampant in the US, and you have a significant private insurance sector in that.
Steve, can I ask you, is there any system in the world of universality that seems to be able to defend itself against cost escalation?
Well, I think the systems that tend to ration themselves better are the the NHS systems, the sort of traditional beverage systems. But even I think some of the social health insurance systems are starting to learn from some of the rationing that goes on. And I actually think the Taiwanese system, which is a single fund insurance system, is not at all bad.
Thank you for that very interesting presentation. Dermot O'Sullivan from Older and Boulder. Just more question to the Minister's initial address, and the Minister spoke in the context of population ageing about chronic disease management, and while bearing in mind that we're one of the youngest populations in Europe, it's a question around the primary care and how it's going to be envisaged and realised, and it's a question that another speaker brought up earlier. What's that mix going to be like? Are people going to be able to manage polypharmacy, comorbidity and chronic diseases within a primary care setting? Are we, in terms of primary care team and their mix, are we going to see gerontological specialists in those teams mix? We know at the moment that in terms of the measuring of primary care, that it's apples and oranges. There are a number of very comprehensive what would have come under the original model for primary care teams, and then there's others that are very loose and don't link up. So the question is, do you think within, as we move forward and the reform of primary care, that there's going to be those kind of specialists and those services that will allow people to manage their own health, comorbidity, chronic diseases and polypharmacy at a primary care level without recourse to acute and hospital settings?
I don't know.
Well done. It's on camera, and it'll be sent to him in the post or whatever. Yes, please.
Thank you. This has been an informative morning. Just a little question. I know the HSE has those statistics, performance statistics, up on their website for hospital for the different. Is that a really positive move? Is there a lot more that they can do? Because it's a bit concerning when they talk about targets. I know you need momentum when you're doing reform, but we know there are problems with waiting list targets and these things. So I wondered if those stats are something you really back.
Well, it's great to have more data as a researcher. No, I mean, but seriously, I think that the point about the lack of transparency and accountability is very important. And I think that is something that has been taken to heart. So I think it is good to have this regular production of statistics. Now, the issue is, well, what statistics do we show? And can we massage the statistics? And both those things can be politically loaded. But I would generally endorse the whole thing of getting more information out there. But then you need to judiciously filter through it. I mean, with the question marks about the number of primary care teams and which primary care teams are actually functional, and I mean, there's some. So I mean, some of those figures are probably a lot more jelly-like than some of the issues around length of stay and throughput in terms of hospitals, where the data is probably pretty good. So generally, I would applaud having more information and more.
Have already been made, and it may be dismissed as a question for the minister. But I do think that it's somehow an underlying assumption in all of the morning in relation to membership of the primary healthcare teams. I noticed that it's very much a medical model, and if we're talking about health care and primary health care, I'm wondering if people like nutritionists, social workers, social researchers, people who know a lot about exercise and yoga, and people who know about lifestyle choices should not be included in that whole area if we're not to just return to treating illness. Thank you.
Yeah, I mean, absolutely. Have we got a sickness health system, or are we looking for something else? I think to wrap up the second session this morning, what I'm hearing is very much a plea to begin to look at these issues on the ground, to go beyond a narrow biomedical model